Very good.
I'm fine, thank you. Well, good afternoon. Good to see everybody today. Welcome to our current topics of healthcare series. Today we're very pleased to have with us Richard Brown. He's going to talk to us about ways to get here. Spiritual conversations in healthcare. Richard has been with Trillium since 1994, he just told me, so he's starting his 21st year of service. He directs the Pastoral Care Training Program and has a lot to do with the ethics consult service and a whole bunch of other things that I'm sure I'm not aware of. But Richard, it's really great to have you. We appreciate you doing this today, and I'm sure it's going to be great.
Thanks, Dave. Appreciate it. Well, good afternoon. So, can y'all hear me if I yell?
That's why we moved over there.
If I put on my preacher voice, will we be okay? Which I really don't have a preacher voice because I'm not one, but anyway, if we can kill that. So, hey! I was getting ready to think, okay, about 15 minutes of this and my voice will be gone. I want to spend some time today around this interesting topic, spiritual conversations. It really is okay. And I want to have some time just to have some conversation with you about this topic. Several years ago, I was asked to present at the Physician Symposium on Spirituality and Health. In preparing for that, I really sort of got the bug for having these conversations with people outside of chaplains because I do that all the time. So I started really getting interested in this topic about what's it like just to have spiritual conversations with that, and what does that mean, and what are the obstacles and the opportunities that arise out of that. So I want us to talk a little bit about that today. I want to present you some research just to sort of prime the pump, and then we're going to end with some more conversation. These are the objectives. I want us to talk briefly about spiritual history versus spiritual assessment. I want to talk very briefly about what is it the patient wants, but I want to spend the bulk of our time on this last one. How do I do this? How do I have a spiritual conversation? What does it look like, and what do I need to be mindful of within that process? What's interesting, whenever we do a conversation like this, it's kind of different. This is not like Anatomy 2. If this was day one of Anatomy 2, we would all have Anatomy 1, so we would all be coming into the class with sort of a common experience. When we talk about spirituality, when we talk about emotions and feelings and our experience with patients, we all come at this from a very different place. So here we are, or you are here. You can read that either way. Now I'm curious, what was it about this topic that brought you here today? And I never ask rhetorical questions. So what was it about this that brought you here?
Now, I feel like you need to include this when you educate our students, that they need to acknowledge the patient has other interests.
Okay.
Spirituality.
Okay. So I need to include that realm of the patient domain?
I think you should.
Yeah, okay, good. What else? What brought you here?
I think a lot of patients, whatever their worldview is or their religious beliefs are, I think that most people have some kind of faith in them. So I think that we should be able to talk to people in a way that doesn't particularly push what we believe, but maybe opens it up so they can talk freely and feel comfortable in that situation speaking. Okay.
And you see this as a way to sort of help sort of gain skills, or?
I think so.
Okay. Somebody else. Why about this topic? Yeah.
So I'm Faisal Siddiqui, I'm from critical care. So one of the things that I think, is very important, especially at sometimes is the fear that patients perceive. And I have no real idea how to overcome that fear. I mean, is this fear of dying? Is this fear of religious or spiritual or whatever?
Sure.
So I just wanted to have an idea of how to initiate that discussion, or maybe just put their mind at ease somehow. In my line of work, we see a lot of patients who die, like on a daily basis. It's unfortunate, but it happens all the time. And it'll probably be easier for me to understand this a little bit, and word it a little bit better to my
Okay, great. Well, that sort of leads us into my next couple slides for us to talk about. When you think about your experience with spiritual conversations, what thoughts, insights, or questions do you bring? When you think about having spiritual conversations, what sort of comes to the forefront of your mind?
Well, the first thing comes is what is his or her spiritual belief.
Okay, so what is their spiritual belief? What framework do they come out of, and what are they expressing to me? Okay? What else?
Next, sort of the term spiritual, what does that mean
What does that mean?
to that person, and how do we have a common dialogue, common terminology?
Yeah.
Just,
Okay, yeah, we're going to talk briefly about that when we look at one of the studies I'm going to present. And what else? Other thoughts, feelings? Oh, excuse me, no thoughts or insights?
Well, I've signed up for the program on No One Died Alone, and and I've been thinking about it, and you might be the last person with that patient, or with that, you might be the last being that person sees before they actually pass on. So it's very important to know what their desires are for you to share with them.
Yeah.
And not just one what you can share and what you can't share. But like he said, it needs to be their needs, not your thoughts.
Okay, so what I hear you saying, that there's a burden
It is.
about being responsive and receptive to a person in a critical time in their life. Okay, good. Let's sort of change this question a little bit. What feelings does this type of work evoke in you? That's a very different question.
Curiosity.
Do what?
Curiosity.
Curiosity for what?
I think that anytime you're treating a patient in whatever way your specialty treats, is that you never just treat the body, you're treating their mind and their spirit. And so it's finding that connection. And so I'm curious, and I want to be in the right place for them.
Okay. Yeah.
And a little nervousness, you don't want to, not knowing, all spirituality, you don't want to say something that's going to be offensive or, impose your viewpoints onto them.
Okay. Okay. Other feelings that you attach to this? So what are the challenges and the opportunities of engaging someone in spiritual conversation? What are the challenges or opportunities that may come with engaging people in spiritual conversation?
I think one of the challenges is just not knowing how to do it,
Okay?
how to approach it, or
Yeah.
how to have a conversation.
How do I start there? How do I even begin going down that road? Yeah. Okay?
And also, they might ask you a question you don't know how to answer.
Oh yeah, okay. I did a Conversations in Ethics a couple years ago about when the patient asked the health provider to pray for them, and man, that was full of energy because it's like, oh my gosh, somebody's asking me to pray for them, and I don't even pray myself. What do I do with that? Not me, but yeah, a challenge with the comfort level of engaging that. It may be intimidating for us to initiate it, but maybe even more so when they initiate it with us. And how do we do with that? So what's behind that? What's behind that? That angst of moving in that road.
Lack of knowledge.
The what, Dr. Whitman?
Lack of knowledge.
Lack of knowledge. Yeah. What do I do with that? What if they ask me a question I can't answer? What does that look like? And then somehow I think, does that mean say that we're not really competent in that? Because we are highly competent people in our profession. Most people have some sort of background in religion or church or spirituality And that's vast. You know? And so there's a piece of that spirituality is a common thing among us. More so if a patient comes to our oncologist with a new diagnosis of cancer, yeah, they may know some things about cancer, but there's probably not that common connection as we are spiritual beings with that. Great. So let's talk a little bit. I don't want to spend a lot of time on this, but we sort of need to set the framework between what is spiritual and what is religious. And for me, it's very simple. Spirituality is that quest, and the important part is the relationship for something that's bigger than me, for something that's transcendent. It's God, it's bigger than me. It's my quest for that relationship. And you'll see he says a little bit more about that. The individual includes the popular, but it's difficult to define and quantify. That's sort of an important piece of that. Religion, and I'm going to boil this down to one thing, it's a system in which I fit. A system in which I fit. These are people that have common thoughts, common beliefs, we share a common creed, we have a common worship styles, but it's a place in which I fit, in which my spirituality is nurtured with that. Talks about creeds, community-oriented, responsibility-oriented, can be decisive, but it's much easier to define and measure. When you're reading a lot of research articles on spirituality, they will typically couch that with the word religion just because of this. It's easier. It's a system. You can measure that. You can look at that. It's a whole lot easier to talk about religious norms than it is spiritual norms. So that's just sort of our priming our pump. Here's a study I want us to look at. Fairly old, December of 2003. And it basically asks about hospitalized patients if they were religious, spiritual, both or neither. And this is what the survey found. When you see this, what questions do you ask?
How can you be religious and not spiritual?
Okay, how can you be religious, not spiritual? What else?
How can you be spiritual and not religious?
He copied me.
Thank you. Okay, what else?
Were they given definitions of what religion?
Yeah. Well, I'm not sure how does the survey define these things. So what are they trying to measure with that? So if you look at this, there's some things I really question about. But there's some great things that I take away from this study. What else do you see here?
Majority were religious or spiritual.
Okay, a majority, 88% said they connected with some sort of faith, religious experience. There's another piece that's really sort of informs me with this.
Documentation is just it's very small. Just 3% doesn't believe in anything.
Yeah. I'm not sure about that.
They're so small.
Yeah, I'm not sure 3% sounds kind of high, people that have no belief or no faith or no trust in anything.
Most of them are over 60.
Do what?
They're over 60.
Yeah, what does that piece tell you?
Old people.
This is a study of older adults. Now, we are living in a post-denominational era where denominations are becoming less influential. You know, it used to be if you were Methodist and you moved to Alabama, you found a Methodist church. That's not the case anymore. People connect with those systems in which they fit, in which their spirituality is enhanced. The label is becoming less and less important. Another study, and you're going to see a lot of things by Harold Koenig from Duke because he's one of the gurus. We were just talking about him just a minute ago. He did this study of 337 patients, and the question was, how much does your religion, and we can say spirituality, help you to cope? If you look at this, 90% said either largely, most important, or to a large extent more than the 10%. How many of you do clinical work, clinical practice? Okay? Tom, how many patients do you see on a day?
36.
What?
16 to 20.
16 to 20. Well, what does it mean that 90% of those use their spirituality or religion as a coping tool? That's 13 to 14 of those, or 14 to 15 of those really, that see their faith as a coping tool. Think about the patients you see. 90% of them. And what does that tell you when you think about that?
We need it. It's important.
We need it. It's important.
And that we should be able to open up those conversations and feel more secure about and not be intimidated by opening them up. Because if you have that high of a percentage that have a spiritual belief or a religious belief, then they're going to be open if you keep it generalized and not specific to your.
So what does it mean to take a spiritual history? I want to shift gears a little bit as we're continuing to prime the pump. A spiritual history is simply getting information on a person's spiritual life. And also how they cope and how their present healthcare crisis affects that. Now this is one of those areas in talking with healthcare providers, we do histories all the time. You do a physical history, you do a substance abuse history, you do a psychosocial history, but somehow when it comes to that spiritual history, we freeze up. Oh, well, I can't do that. I'm meddling now, But we ask the sexual history, we ask all these other histories. And I think one of the challenges and one of the opportunities for us in healthcare is to start looking at a spiritual history, just collecting some of that basic data. For some folks, is a great first step. They said, I've always been intimidated of having spiritual conversations, but when I start talking with them about doing histories, they start saying, well, yeah, I can gather some basic information. Jamma says some basic stuff is, are you a member of a church? I mean, that's probably one of the pretty universal things we talk about. Does your spiritual beliefs help or do they hurt? How do they influence your medical decisions, and how do those beliefs either support or conflict with what's going on with you right now? These are very matter-of-fact things. I think every provider, if you've never done any spiritual inventory or inquiry, you can start doing some of this history stuff with folks. And that just may help the patient say, this provider really is concerned about the whole of me as well. A mnemonic to help her remember. These are some things that I want to address when I'm talking or doing a spiritual history. What is their faith? How important is their faith? Do they belong to a community of faith? And then, how do you need me to address those things? I mean, very simple, 4 little questions you can use to start asking your patients that sort of start moving you into how do we broach that spiritual religion conversation. With that. So anyway, again, this is not a lecture on spiritual assessment, but I want to let you know there are tools out there that model that. The Hastings report talked about some times when a spiritual history should be included, and you can see the things that they came up with there: new relationship, chronic illness, major surgery, pregnancy, trauma, and is approaching death. What's the common thread of these? Do you see a common thread?
Stress.
Do I?
Stress.
Okay, stress definitely is one. So,
Transitional time.
transition. Anytime someone's in a transitional time is a great time to do that spiritual history. Why? Because people in transition are reevaluating everything in their life. How many times have you heard, or maybe you've said, well, I'm going to be moving to Ohio. Well, when I get to Ohio, I really think I'm going to find a church and get involved. People use times of transition to reevaluate their lives and to make changes with that. So what I see here is transition, and transition is a great time because people are seeking that, they're looking for that. So, this is where we get fun. What makes a spiritual history different than a spiritual assessment? Think about the histories you write and the assessments you write. Yeah, no rhetorical questions here. What's the difference? What do you think when you see that? Is there a difference? Or when you saw that list of things about when to do a spiritual history, did you say, oh, that's a spiritual assessment? Were they synonymous?
Well, history, when you take like things like history, social history, family history, it does involve other people or other things from the past.
Okay.
The family history, it's not, you're looking at cardiovascular risk factors in family members, not in yourself. An assessment is more of yourself. So the spiritual history might be more of what you were raised in, what your community is, and then the assessment might be more of where are you now with all this? What does it mean to you in the present? Or something like it.
Okay. Other thoughts on that? Yeah.
See, a spiritual history is, you're asking the facts, you know. And do you have a belief? Do you have a community? And, you know, it's getting down the facts. An assessment is this going to be a strength or a weakness in how I interact or treat or work with this patient?
Okay, good. I like that. Yeah, you know, when I think, you would say something now?
That's what I was going to say is,
Okay.
one is taking information and now what do I do with that information?
Yeah, and what does it provide me about how this person is in the moment? And for me, the spiritual assessment comes down to either two things. Are they coping normally to the situation, or are they spiritually not coping, or are they spiritually coping incongruent to the situation? A history is getting all the pieces. There's actually a spiritual assessment out there that has 49 dimensions. I could maybe do one of those in a day. You know, if you think about trying to assess 49 different dimensions. But part of that is, how do you bring in the current context, the medical situation, their faith, their history, all that stuff, and then how do you bring all that together and make a statement that says, this is really working for them right now, or this is not really working for them right now. And where this gets really interesting is, what if you have a patient who just found out that their, say, 10-year-old daughter was run over by a drunk driver, and they're just angry at God? Well, is that normal to the situation, or is that incongruent? This is the part where, if you look at this is the thing about spiritual assessment from the American medical colleges. Says they must be void of being judgmental when the patient's beliefs and values conflict their own. It gets really interesting, because if your faith tradition says, oh, you can never be angry at God. God's good for you. God's creating you. God's always for good. God's good all the time. Then therefore, anger at God is incongruent based on your understanding. But maybe not based on their history. And this is the point where that spiritual assessment and the spiritual history sort of go hand in hand. And this takes a lot of time. It means moving ourselves out of the way so we can really connect to the person, to listen to their history, to listen to their faith, to listen to how they understand God. For some people, being angry at God is just unheard of. For me, anger is intimacy. You know, when I can share I'm angry with my wife, that's a very intimate emotion for me. And that has great rewards and great benefits to us, because I feel safe. I know she's not going to abandon me. And all those things sort of hold true with God as well. But for other people, the anger of God, oh, you can't do that. I'll never be angry at God. God must have a better purpose for this than what I understand. So we need to understand when we're doing this assessment, it's going to touch stuff within us that we may agree with or disagree with. But then how do we sort of compartmentalize that in a healthy way so that we can understand where the patient is coming from? Several years ago, I was doing a presentation at a hospital out in Southwest Virginia about clinical pastoral education, because they were entertaining the possibility of developing a site out there. And I went out and I spent a couple hours with their chaplaincy staff and hospital administration talking about clinical pastoral education and what that was like. And at the end of my time, we were doing questions, and this guy on the back row said, so let me get this straight. And whenever someone says that, I'm like, oh wow, what's this going to be? So he says, so what you're telling me is you're going to train me to discard my faith so that I can be with someone's faith that I don't believe. I said, no, that's not what I'm saying at all. I'm saying this is about being so grounded in your faith that it doesn't threaten you to walk with someone else for a while. And thank goodness the light bulb went off. Because I didn't know what else I had to say about that. And they said, oh, okay, I can understand that. And sometimes in our work with patients, whether they're different religions, and yet really people have an easier time with a different religion than different levels within their own tradition. The conservatives struggle more with the liberals within their own denomination than they do in caring for the Buddhists or whatever, because it's so close to us. And when we start doing this spiritual conversation, it enables us to walk with other people and say, you can be different from me, that's okay. I understand that, I will support that. I may not agree with you, but I don't care for you. I'm going to sort of journey with you with that. So when we start talking about the assessment, that's what, for me, it boils down to. Is it working for you or is it not? And then if it's working, well, great. We're going to support that, encourage that, and we're going to continue to reassess that as we go through treatment. If it's not working, we're going to intervene. I mean, that's what we do, right? Now, other areas of our life, if it's not working, we're going to make a referral, develop a plan of care, encourage them to find those resources so that we can support them in their process. So, we primed the pump. Boy, it took us a long time to prime our pump. Okay. So, what does it look like? How do you invite a spiritual conversation? A couple of things I've learned. Spirituality and faith are great words to use because they provide openness, not do you belong to a church? Well, what does do you belong to a church tell you? They're on a roll somewhere. That's about it. So spirituality and faith. Well, tell me about your faith. If you're a spiritual person, just start asking your patients those questions. And what those words do is it allows the patient to define that for you. Tell me about your faith. How do you understand that? Some more questions. What importance does your faith or belief have in your life? Not just are you a member. How important is that? How important is your faith? That's a great question. Is there a meaning in this, meaning whatever the crisis or the hospitalization is, that is larger than what I see right now? I mean, 15 years ago I was called to pediatrics. And I went in and I met with a mom who was in the hospital with her youngest child who had cystic fibrosis. And as we started talking about that, I come to find out she had 2 other children, both of which had chronic diseases. Young mom, mid-20s, 3 children, all chronically ill, devastating diseases. And we started talking about that. And I asked her something like this. I said, well, does this situation, does it point you to something that's larger than just what's going on right now? And she said, yeah, it does. I said, can you tell me about that? She said, yeah. She said, when I was 18, 19, 20, she said, I had 3 abortions. And my 3 children now are God's punishment for that. Yeah. So, is there a meaning in this that is larger than right now? One of the challenges when you start going down this road is to be prepared for what you could hear. Because I've heard stories over the years that have said, you can't make this up, you know. There's no way you could create this just to say that. So it does move you into that. Another good question is God a part of this illness right now? Is God a part of this injury? One of my best spiritual care tools is I play stupid really well. Playing stupid is my spiritual gift. Because people learn about themselves when you ask them to teach you. Tell me about your faith. Teach me about your church. Help me understand where you find meaning in that. You know, if I just take a back seat and let them teach me about that, one, I'm going to learn a lot, and two, most people find what they're looking for if you give them the chance to start teaching you about their faith and their beliefs. Couple more slides, then we're going to talk. Alfred Adler, big fan of his in personality development, because he said that we all attach meaning to events in our lives, and when we attach meaning, it gives points of reference for our behavior. I see this all the time when I talk with families that say, I don't want a feeding tube, or no, we're going to code this person for 3 years. Well, why are you going to do that? If you start talking about them, you start talking about the meanings that they have in life, and you understand why they attach behaviors to that, and how they make medical decisions if we can take time and do that. So what's the cost of not addressing spiritual needs? Well, it's really expensive. 2 studies here. One of them says that people who said, yeah, I use religious coping as my support system, typically at the end of life, want more ventilation, more CPR, more drugs, and all the gamut. A follow-up study, which is the bottom part, that basically says people who use religiosity and spirituality as coping and feel that their healthcare team is receptive or responsive to their religiosity, they had a 5-fold increase in hospice referrals and a 72% decrease in extending life. 72%. Now you tell me that's not a cost-saving factor with that. And this slide I just love. What are the results? This is a great study I just found in the last couple of weeks by a guy at Bowling Green State University. And this is some work that he is doing in talking with providers about the effects of them having spiritual conversations in their practice. Look at some of these things. 46% said this moment being the spiritual conversation felt set apart from everyday life. 65%, I felt that I was part of something really real. 61%, I felt a deep sense of connectedness with the patient. 57% said it helped me develop some deep gratitude. 9%, I felt like time had stopped. And I thought about that because just a week ago I did a presentation on physician burnout and compassion fatigue. And one of the big things there is a loss of connection. And I began to wonder when I looked at this stuff right here, these percentages, if we can start having this kind of personal feedback or response to having spiritual conversations with our patients and families, what will that do for our level of compassion fatigue and our own sense of mental well-being? So what does it look like? How do you do that? Well, I did it with you when we started. Why are you here? What are you looking for? What are your thoughts? What are your insights? I was assessing you. I was having a conversation with you. I was finding out what was meaningful for you. I was finding out what was important for you. I was trying to find out your experiences, what you brought to the table. What feelings do you have? What's this feel like? Now, if you think back to 40 minutes ago when I did that, was that a very comfortable place to engage you in that? I hope it was. because I was curious about you. You used the word. You wanted to be curious.
Yeah.
Curiosity is all about assessing people where people are spiritually. Well, what do you think about that? What do you think about all this stuff?
Yeah, I would say that I think it's vitally important, and I was fortunate enough to work with coding for a couple of years at Duke on this stuff. And the issue is always it's time. I find on an inpatient ward at an academic institution, I probably have more time to do it than anywhere else I ever was before, just because there's time pressures to see the patients. And I also think it really speaks to the need to really integrate chaplains and others when like how we identify which patients might have more needs and how to get chaplains there, as opposed to sort of chaplains showing up and saying, "Ooh,
Right.
what's the need
Yeah.
here?" And
Who can I see today?
and then some people are just more comfortable talking about them than others. Some people are more able to engage in these dialogues with patients than others. And with the students, I always try to emphasize at least trying to ask the questions. Even if you're not comfortable with the dialogue, at least try to ask some questions about it.
Yeah, and even if you're not comfortable making the assessment, well, is this a normal coping tool or is this a maladaptive coping tool? At least we can start by at least having the conversation. And when I came in today, I wasn't expecting anyone to have a huge pendulum swing. That's where you went out the door with your, with your religious text and said, "I'm going to go do this." My goal was that when you leave the door, you'll just think about that. What does it mean to have spiritual conversation? What does it mean to have dialogue with someone? What does it mean to sort of incorporate the spiritual realm into my everyday practice? When I teach my students in CPE, it does take practice. You don't just start doing it. And when you first start initiating spiritual conversations, it can feel really awkward. It can feel really like a third thumb, or it just takes practice doing it. You have to just keep integrating those conversations.
Picking up on what you said, Tom, I think you make a good point when you, the way in which you ask questions and brought us into it, you could tell that you had some practice, that it was inviting, because it is always, I think, had to go through a bit of discomfort because we're being tested. You're asking questions, and it exposes some vulnerability. And so, but you helped us to quickly get there, because it wasn't, I'm not looking for you to answer what I want, but trying to ask the questions in a way I want to understand from you.
Right, yeah.
And then the trust.
Right. Which is a whole different area that we didn't talk about, is when we start asking those this happens with chaplains all the time. Chaplain goes in and asks questions, they give us the answer they think we want to hear. We say, really? It's where it takes some time before people start doing that. So that time thing is really important, and I'm mindful of that as well. And how do you find the balance, especially on the medical side, when you have 16 patients to see? What does that look like? How do you incorporate? How does that become a part of the process that's helpful, not only for the patient, but also for you as a provider? And so what does that look like? It's a challenge. It really is.
Can I ask you?
Yeah. We probably see, my staff probably each see 10 to 12 a day. But some of those are 5-minute checking in, follow. Other thoughts? Our time is about upon us.
It seems to me that there is that point that is where the physician or the caregiver, whoever it might be, that you've got to make the decision, am I going to treat the patient or am I going to treat the person? And in some instances in how we practice medicine today, we're treating patients. because we got to get them through. And that moment that you caught in those quotes and things is when we begin to see that person in front of us as a person. And so that revives that connectedness. And whether we're able to take that moment and to make that happen or to allow it to happen. And I think there's a lot of fear in that boundary of how do we let go in that moment and be open to hearing that person and seeing them more as a whole than just as this medical patient.
It's 3 or 9.27.
How?
It's 3 or 9.27 or whatever the ICD code is.
Right.
How do we not treat the code, but how do we treat Tom? How do we treat NL? How do we treat Ahmed? How do we do that? And you're right, there is cost with that as well. Goes both ways. Okay. Thank you for your engagement. Thank you for having a conversation with me. Maybe a little bit different format for one of these things, but thank you for your participation, for your interest. So appreciate it.